Hi, everybody. I want to welcome you to the Resident and Family Support Council meeting that we host on the second and the fourth Tuesday of every month. The link that brought you to this meeting today is the same link that will bring you to all of our meetings on that second and the fourth Tuesday of every month. I also would like to thank the Illinois Pioneer Coalition for letting us use their Zoom account. They've been very gracious in allowing us to use this account so that we could use this same link for each of our meetings. So thank you to the Illinois Pioneer Coalition for that. We conduct these meetings as a way to help empower people with information. It's always the more information we know, the better that we can do to make sure that those people that are living in long-term care across Illinois and across the country actually can do well and have a good life. And that's really what part of this conversation is about today. I know we've talked about residents' rights frequently during these meetings, and really basically at the core of everything we talk about, these residents' rights are really that's the core of it, the whole thing. But today I wanted to get everybody's perspective on what some of these rights actually look like in the real world, not just on paper. What do they really look like and feel like? So I've actually even invited Lisa Light, who is one of our newer regional ombudsmen. And I wanted to invite Lisa into this conversation today because Lisa has a different perspective being newer into this path as an ombudsman and some of the experiences that she's encountered. So I'm going to be throughout the time. I want to just say hi to Lisa right now. Hey, Lisa, how you doing?
Hi, I'm fine. How are you today?
I'm great. I'm great. Thank you for joining us. And I also would like to invite anybody into this conversation. So please do feel free to go ahead and you can raise your hand if you look at the bottom of the screen. If you go to reactions, you can look at that. It says reactions there. You can click on that and it says recognize hand jack. Well, I think that's where it is. I'm actually looking to see. They've moved it on me. So I'm not really sure. Do you, Stephen, do you see how?
Yeah, it is still under reactions. So if you click reactions, it should be right there at raise hand.
Got it. Okay, perfect. I see Mary. Mary's done it. Thank you, Mary. I appreciate it.
Hit it accidentally. I apologize.
Oh, no, that's good. So that's where you would find it under reactions. Don't hit the little arrow going up, just hit the reactions button and you'll see it right there. You can go ahead and you can raise your hand or just go ahead and unmute yourself and bring your picture up on the screen if you're not currently on the screen, because your picture will pop up and that will also cue me in that you've got a comment that you want to make around that right that we're going to be talking about. So what I'm going to do right now is I'm going to start a PowerPoint for today that we'll use to help us guide us in the conversation. Okay. Okay, so there we go. So understanding your rights as a resident in long-term care. So like I've said, this is a really important conversation that we're having today because this is the core of everything that your world should be looking like when you live in a long-term care facility. One of the things as ombudsman for the state of Illinois is we really are there to protect and improve the quality of care in life of residents through individual and systemic advocacy. And really the way we do this is to ensure that residents' rights are being upheld. That's what we do as ombudsman, and that's really the basis for everything that we try to do. And just to give you a quick overview about what the type of facilities is that we work with as the state ombudsman. We work with nursing homes, that's skilled and intermediate care. People may also refer to them as rehab facilities, as a short-term rehab facility. That is also what a nursing home would be classified as. We work with the state veterans homes. There's only 5 state veterans homes in the state. We work with those. We work with those buildings that we refer to in Illinois as assisted living. So we work with, and then also supportive living. Supportive living is very similar to assisted living, and that's extremely unique to Illinois. Supportive living facilities. We work with sheltered care facilities, intermediate care facilities for the developmentally disabled, specialized mental health rehab facilities, and medically complex for developmentally disabled. What we don't work with, though, is we don't work with independent living facilities. We don't work with SILAs, and we don't work with state-operated facilities. So it's important that we do not have jurisdiction in those areas based upon the federal and state regulations. The reason why I wanted to share this is so that everybody's clear in understanding that. If you want more information on this, pop it into the chat, and we could do a presentation on this. We have done it previously, and you could find it on our YouTube channel. But I know we haven't talked about this in a while, and people might want us to talk more about the different types of long-term care facilities that exist. So pop it into the chat, and that way then we'll know that this is a topic that you might want to talk about. So residents' rights, where does this all come from? The Older Americans Act of 1965 actually is what established residents' rights, really under Medicare, for Medicare and Medicaid funded facilities. So this is where it all started, way back in 1965. And then in 1987, there was actually an Omnibus Reconciliation Act that was put into play. It was referred to as Over 87, and that really established residents' rights to maintain that high quality of life when people living in long-term care facilities. So that was a big thing that happened back in 1987. In 2016, then there were actually more federal regulations that really did help make sure that rights were being honored, and there was some advancement in what those rights look like. And then Illinois also has several regulations in effect to support residents' rights in the variety of different entities that I just reviewed for supportive living, assisted living, nursing homes, and all of those. So they're also spelled out specifically under those guidelines as well. Just wanted to talk about this just so that everybody understood that this is in law. This is not just something that looks good on paper. This is in statute. This is something that all long-term care facilities need to be abiding by. And it's really important to know that you don't give up any rights just because you move into a long-term care facility. You still have all the same rights that you had as anybody who lives in our country. And many times it can feel like the world looks and feels very different when you move into a long-term care facility. And it shouldn't. It shouldn't look or feel different for anybody because you have those same exact rights that you had prior to moving in to a long-term care facility. And that's one of the things that actually, when we were talking about this, Lisa and I yesterday, we were just talking about some of the surprising things that she's encountered as somebody who is really focusing in on this through this changing career paths for her. And so, Elisa, you shared some things with me about families and how families and rights kind of sometimes it feels like they're not working together very well. You want to elaborate a little bit on that? Can you unmute yourself?
Sorry, forgot I was muted.
That's
Yes.
okay.
So when in the training and just from doing a lot of reading and researching, it talks a lot about how we need to worry about making sure that the facilities are being respectful of rights and helping residents understand their rights and make sure their rights are being met. So I was surprised that what I've run into quite a bit is not the facilities who are not respecting the rights, but actual family members who I guess get overzealous and really let some of, especially the POAs, feel like that they can make every single decision for the resident. That was very surprising to me. I've had POAs even try to say, oh, my mom can't eat fried chicken. I don't want her eating that. She's not allowed to eat that. And just explaining and working with the families what is acceptable for their loved one to do, that they have the right to make their own choices.
Yeah. And that, you know what, you're not the only one who's ever made that comment. I know I've experienced myself with that. And it does, I think, one of the things we have to recognize is families love these individuals, and so many times, we want to protect our mother, our father from something that we might not approve of in our world, or that we just, that might be, my mother may have never had chocolate all the time. And all of a sudden, as she's getting older, she wants chocolate. And so I may try to take that away from her because I know she's always been very conscious about her weight. And, and I may start putting some barriers up against her. And when the facility is giving chocolate to her all the time, whenever she wants it, and she, has no health issues and she wants to take it, even if she did have health issues. And, all of a sudden families will start to interfere with some of that, sometimes thinking it's in their mother's best interest not to have it. But if they were home and they wanted it, they would be able to get it. And that's the piece. I see Mary has her hand raised. Mary?
Sorry, have to unmute.
Yes.
And I think it's important to make the note of a POA was mentioned, a power of attorney.
Yes.
And we know it's a medical power of attorney. That only goes into effect if the person is unable and declared unable to make their own decisions by a medical professional. And that, I think, still has to go through the court system. It can't be made without the court certifying it. And I could be wrong in that. That's my understanding of it. And I don't know if a regular power of attorney without the medical piece to it, but an overall power of attorney has the same thing to it, that the person has to be unable to make their own decisions. But that's an important part of that, because, and the reason I'm concerned about that is, in my experience, I've spent 2 years in a nursing home. I've been resident council president. I've been part of a group that advocates for nursing home residents. And what I've seen is the facilities are saying that that person can't make their own decisions repeatedly, constantly, saying that if they have a POA, whether it's medical or not, that person has no ability to make their own decisions, which simply isn't true.
Mhm.
So the family does think that they can make every single decision for that person.
You're so right, Mary. So just not to go too far down the POA rabbit hole, the power of attorney POA, not to go too far down that rabbit hole, but there are two types. There's power of attorney for property, and there's also power of attorney for healthcare, health, property, and finances. And then there's power of attorney for healthcare. So there are two different types. It can be the same person, but there are two different types. And many times, as ombudsman, we see the same thing happening. We see that the power of attorneys, as soon as somebody moves into a long-term care community, many long-term care facilities feel that the residents give up their voice. A power of attorney does not kick in until somebody loses their voice. It does get set up in a legal manner, but it doesn't go into effect by getting certified. That would be more of the guardian piece. So I don't want to go too far down this rabbit hole. But
And Lee, specifically, when you say certified, you mean going to court?
yes.
Correct? Yeah, so you don't have to go to court to certify a power of attorney. Typically, it's just when a doctor says they can't make the decisions, or sometimes when a facility or a family member sees that the resident cannot give direction on something, then they go to the power of attorney. It all kind of depends on how that power of attorney is written. Some of them have that requirement for a doctor's order written in there. Some of them don't.
Mm-hmm. Yeah, and it's very individual. You get to do what you want to do with that power of attorney.
Mhm.
Like I have a power of attorney, and my children right now, I live at home. I'm decisional. I can articulate what it is that I need and want. And there's no way that my kids would ever try to jump in and say, Mom, you can't do this. You can't have that. And if I moved into a long-term care facility, many times that's exactly what does wind up happening, just because I have one. And that doesn't mean that it kicks in because I moved in to a long-term care facility. It just means that I have this for if and when I lose my ability to be able to articulate what it is that I want. Sue, I noticed that you have your hand up.
Yes, I'm not going down that rabbit hole either, but it's not necessarily just the facility that's doing this. It's families that do have power of attorney, and there is not the best of relationships between the family and the resident. And this is their opportunity to finally take control of everything. They know
Mhm.
darn well what the power of attorney covers, but that's where the facility needs to step in and say, whoa, stop. Your mother, father, sister, brother, whoever can make the decisions for themselves. They do have the choice. So it's not necessarily the facility that's at fault. It
Mhm.
is the family that's at fault.
Yes.
And so it's kind of a two-edged sword there.
Absolutely, Sue. And what you said is so on target because we see it as ombudsman. I think that's Lisa's point. She was really surprised as a new regional ombudsman that families were interfering with people wanting to make their own decisions because they were the power of attorney. I see that Jennifer, you have your hand up.
Yeah, I've got that in a situation with my family member. My mom would like to go and have outings and go to church, and the medical POA made a rule, just said she cannot leave the facility, and he even expanded it to first I thought it was just she cannot like leave the grounds, but now it's to the point that she cannot go outside of the facility and cannot sit outside the front door under the shade and be outside. And I did contact an ombudsman for her area, was told that no, she shouldn't be a prisoner in her own facility. The facility should be pushing back to the POA and say, well, what is the medical reason for this? If he has no medical reason, then they should be working to support her that she has this right. And the facility has just done whatever my brother wanted. And so it's just kind of, well,
Yeah.
it's just sad.
It is, and I want to encourage you to continue to reach out to the ombudsman about this, to not let it lie, because even if there is a medical reason that might not be healthy for them to leave, because maybe they're compromised in some manner, health-wise, people get to make that choice, that risk, take that chance. If they really want to leave the building, they should be able to leave the building. It's their life. And that's really important. As ombudsman, this is a conversation that we have so many times with families, with residents, and with long-term care facilities. And it's important that this is truly understood. Donald, did you have something that you wanted to share? Can you make sure you're unmuted?
There we are. I just wanted to put another rabbit hole out there that I don't want us to go down, but we need to be aware that it exists. And for those of you who may not know me, I have become a part of this group in my capacity as the chair of the New Illinois Commission on LGBT Aging. And from that community, I want to say that even the discussion of what family is becomes problematic. And even in this day, when LGBT citizens in the state of Illinois are a protected class and have full civil rights and have marriage equality, still the question of what family is and what its legal connection is beyond a spouse is problematic in this whole situation.
Very true, Donald, and I'm glad you're bringing us to that piece as well, because that is something we all need to be extremely cognizant of. We get to define what family is. Just because we have the same birth parents doesn't necessarily mean that that's my family. Family can extend beyond that. And just because I might not be married to somebody doesn't mean that they're still not my family. If there's somebody who I have deep feelings about. And I think that that's very important that you brought that up. So this is an important piece to this conversation because this affects everything else that we're going to be talking about right now. We're going to be starting to move into talking about a little more, which is the residents have the right to be informed about and exercise their rights. If I've got anybody who is not allowing me to do this because they're my POA, my power of attorney, right there, my right is being violated. So everybody should be informed about what their rights are. You should be given information upon admission that says what your rights are. This should be reviewed with you on an annual basis. And it should be something that you could easily access if you need to be reminded about what those rights are. This is also something that when the ombudsman go around and they to the buildings at least once, at a minimum, once every 3 months, they always bring pamphlets of residents' rights with them. And that's like, we hand those things out like they're candy. And that's important to be able to take one of those so that you can always access that, so that you can be able to really know what your rights are. People feel much more empowered when they see those rights written down sometimes, because then they can point to it and say, I have this right. So I think that that's really an important thing, to be able to just even know that you need to be informed of this, of your rights. Residents need to be treated with dignity and respect and make their own decisions. So this is really that thing that we were talking about. Just because I have a power of attorney doesn't mean that I lose my ability to make my decisions. And even if I have a diagnosis dementia, doesn't mean that I lose my ability to make my decisions. The only time that I lose that ability is when I am not able to articulate. And by that, I mean, whether it's this by being able to point, being able to show people, or through using voice, that's when a POA, a power of attorney, may kick in. Those are the only times. Just because somebody has that doesn't mean that that's it. And just because a diagnosis exists doesn't mean that other people start making other people's decisions. Freedom from chemical and physical restraints. Physical restraints are those things that literally tie people to chairs or keep them from being able to get out of bed in an independent manner. It can look like a lap buddy, which is a piece of foam that gets put on somebody's lap that gets wedged into the chair. It can look like a bed rail that where if I can't lower that bed rail down by myself, then that is keeping me from being able to get out of my bed in a manner that would be actually safe for me. And it also means chemical restraints. Chemical restraints many times gets used to control behavior. And that is something that is a whole other conversation about why that is so important to know that this is not a good thing. Chemical restraints, just as physical restraints. These chemical restraints could look like giving somebody a psychotropic medication because they have acted out, they've had a behavioral reaction to something, and then all of a sudden something gets ordered for them to control how they behave moving forward. And that many times can look like an individual being very snowed, being very sitting there and non-reactive to the world around them. I noticed, Jennifer, you have your hand up.
I think she's had her hand up for a bit.
Okay, no,
From previously, never lowered it, but
Okay.
Sue just put her hand up.
okay,
Unless
Sue,
Jennifer is still has something new.
Sue, did you want to share?
Okay, me instead, okay. I just wanted to let you know that, let me get the number here. Senate Bill 1497 was just signed by, Governor Pritzker. That is one of the, bills that, the group I'm with under, Senator Karina Villa. I'm part of her, senior advisory committee. And we made some amendments to the Nursing Home Act, dealing with chemical and physical restraints. And that is Senate Bill 1497. So that gives a little bit more, clarity to things like emergency, well, we could use it in a case of emergency. Well, define emergency. Is it my emergency or the facility's emergency? So you might want to check that out. Because that was pretty good. That was just signed a couple of days ago.
And this was, and Sue is a part of a group that actually works with Senator Villa in Illinois. And they have done, they've passed two legislative bills, one this session and one last year. And this one was a very important bill because it did help give that clarity to what that emergency situation looked like. And all the documentation that was required as well. So congratulations to Sue and the group of people that she's been working with on trying to make some legislative changes throughout the country.
Thank you. Thank you. I will pass that along to my colleagues.
Please do, please do.
What happened? I think we lost Lee. I think she, her call dropped. I expect she's trying to return.
So I just lost everybody and I apologize for that. My computer just went dead on me. So thank you for being patient. I was able to log back in and I'm hoping it didn't go dead for too long. I tried diligently to get back on. So let me get is everybody okay? Stephen, is everything okay?
We can hear you and see you now, Lee.
Okay, thank you. Thank you so much. Okay, so here we go. Back to what we were talking about. Okay. Let me just put this up and bring it back. And again, I apologize. Okay, so now we're going to talk about this refusing treatment. The residents have the right to refuse treatment. And I wanted to say if Lisa had any thoughts on this as well.
Yes. I guess in terms of refusing treatment, it's more that they don't, I've had a lot of individuals who just didn't realize that they can have more say in whether or not they follow the instructions of the doctor, or if they like to change their medication, they want to take less medication. And even when they do realize that, oftentimes they've been told, nope, you can't change your medication. You can't take less of this. You don't need this. We don't want to give you that. And the residents just don't realize that they don't have to listen. Again, that's their choice. And I have, when I do the resident council or the resident rights training with staff members and with residents, I let them know it. Listen, we all make our own bad choices in life. Whether it's a good choice or a bad choice, we're still allowed to make our choices. Just because they're in this facility now, that doesn't change. They're allowed to make good choices, bad choices, informed choices, or uninformed choices. It is their decision. They're still adults. They're still allowed to do this. I guess I've been kind of surprised by the pushback from the facilities about allowing residents to make those choices when it comes to their medical care.
I think we're dealing with, like, my mother comes from a generation where the doctor prescribes it, I should do it. And my generation, which, I'm a baby boomer generation, and my generation is actually comes from this place of, you know what, I'm going to question it. And do I really need it? I actually had a doctor's appointment yesterday and the doctor wanted to order a test for me. And I'm like, well, what would the results of this test be? She's like, you would just know that you have this condition. I'm like, and does that change the way my life would operate? Is there anything I would have to do? Special diet, undergo some sort of thing, treatment, whatever. And the doctor's like, no, it wouldn't do anything. And I was like, well, then why do I need it? I don't need it. I'm not going to do it. Whereas if it was my mother, I'd be, okay, when am I going to go? And that's part of, you have that right. You have that right not to have that test if you don't want to have that test, to not take that medication. Like you said, to change that dosage of medication. This one I'm feeling a little loopy on. I don't like the way it makes me feel. I don't like the reaction I'm having to it. You increase my dosage. I don't like it. I want it lowered again. Those are things that we get to do. I see that Jax has a question.
Well, it's because I've done both sides. I work in administration and I've worked on the floor. And my question is that, or to your statement is, you don't understand why we continue to say, well, you need this. As a nurse or a CNA or someone on the floor, our job is to do what the doctor tells us to do. And so if the doctor's prescribing the medication, fine, we're supposed to do it. Even if they say no. And in some of those cases, there's been situations where they're like, well, no, I don't want that. And it's metformin or it's insulin. And if they don't take it, then we're liable. So there's a complication of, okay, you have your own right to do this, but then there's the other side of that I'm looking like I'm the one who's at fault because this person doesn't want to take their medication. So that I'm at risk of having my license or myself, infringed upon because I'm listening to this patient who says they don't want it. So I think, and also in some cases where people have dementia, they would sit in their poo for days if you let them. And so even if you say you have a choice, sometimes the choices they're making, even though you said they're bad choices, they come back on us because they sit in that poo and then 3 days later, they have a bed sore. And then 3 days later, IDPH is in there on us. So I see that side, but I also see the side of administration who's like, well, they have to do these rights. We have to abide by this. But where is the gray area of, okay, if I let them sit in their poo all day, because they just don't want to do it, how does that then come back to us when IDPH is going to be in there because they have a level 3 or unstageable bed sore because now they don't want to get changed, or now they've dropped dead because they didn't want to take that insulin. So how then do we balance that? I have this responsibility to my organization and to my license with, I have a responsibility to the person that I'm caring for. So it's complicated is what I see it as. And I find that it's okay to be an advocate for them, but how do you balance that as an organization of saying, okay, they have these rights, but then how do I safeguard my facility on the other end? It's very difficult is how I see it.
Oh, Jax, you are so right. It is very different. This is not an easy conversation because it's so multi-layered. And everyone has a responsibility. As a nurse, I'm the person responsible for medication. So I want to make sure that people are taking their medication as prescribed by the doctor, because I'm the doctor's avenue for making sure that his orders are followed. As an advocate, we are in place for making sure that the residents' wants and desires are being followed. And then there's the facility at large. So there is a way for this to happen. And if a resident doesn't want to do something, they don't have to do it. And we all have to respect that. And then as a facility, the way it gets respected is the education goes along with it. So if I'm a resident who doesn't want to take my metformin and I need to take that in order to control my diabetes, what that could look like from the nursing side is I still continue to offer it to you. I offer it to you every time because that's what the physician order says for me to do. I offer it, I document the resident wanted to refuse it. Then I go to the care plan coordinator, I say, this individual always says they don't want to take it. They just don't want to take this medication. They've got justified reasons. They don't like the way it feels. They feel that they can control it dietarily, whatever that may be. It may not be right reasons according to the medical model, but it's their desires and their reasons that gets honored. The care plan coordinator, then it's up to them to make sure that they write that care plan that says the resident does not want to take their metformin. These are the reasons that they're stating. Staff will continue to educate them on why they need to take this. And that's, it's important to their sustaining a good, healthy condition. And that's how it would be written. And then it would be that we will continue to educate the individual on why it's important that they take this medication. And as a nurse, you would do that every time. You need to take it because this is what controls your diabetes and your blood sugar. And if you don't take it, these are the risks that could happen. And that's what happens every time. These are the risks. You're deciding that you want to take these risks, though. As that individual, you get to make that choice. As a nurse, I've got to make sure that I'm still offering it to you and encouraging you to do it, not making you do it. That's how that has to start to look. And I don't know how you wrap your brain around that. But that's really because if an individual was at home, a nurse wouldn't be providing them with that medication. They would be in their home, giving it to them or not giving it to themselves based upon what they wanted to do with that. Does that make sense to people? Does that make sense? We're not saying that there isn't roles for people. Yes, there are medical roles for people to make sure that people feel educated when they're making these decisions that they don't want to do, they don't want to have a treatment. That's the facility role. That's the professional that works inside the nursing home's role. And you'd be failing if you didn't do that. But our role as an ombudsman is to purely make sure that resident voice gets listened to and amplified if it needs to be, because they're just saying they don't want to do it. Mary?
I mean, basically, that resident is in their home. So there shouldn't be any change of what their rights are from if they were in the home they came out of to be in the facility. So basically, they're in their home, and you can't force anyone. You shouldn't be forcing anyone to do anything in their own home. It's their choices. Even if it's their choice to lay there and, do horrible, detrimental things to they need help, they need counseling, that can be argued. But if the person is consciously making a decision about their medication, I mean, the story that I just heard really strikes home for me because I am a type 1 diabetic. I've been type 1 diabetic for 50 years. When I went into the facility, I was on an insulin pump. They wanted to remove it from me. I had my endocrinologist, who's one of the best in the country. I had my PCP. I actually had a friend who was a lawyer that had to get involved. Luckily they were told that they would get a cease and desist because they were putting my life in danger if they took it. So during this whole argument, I was able to keep it. And I ended up keeping it the whole 2 years I was there. But it was a nightmare to be able to do that.
Mm-hmm.
I mean, that's just wrong. And my diabetes is very brittle and my blood sugars are out of control without it. I had it removed when I was in the hospital a few months before I went in. And I was there for, I guess, about 5 days. And my blood sugars, I had endocrinologist team every single day. And they didn't know what to do with it. So yeah, it was not going to happen. But it was a fight, and it shouldn't be.
Yeah. Well, especially when I see in the comment that you made that sometimes people are told that they're going to be kicked out if they don't follow what the doctor is telling them to do. You are so right. That becomes a threat then. And so then people comply just because they don't want to be kicked out. And that again is an infringement upon their right. You can't be kicking somebody out. Refusing that treatment is not a reason. We're going to talk in a minute about that, why you can leave a building, why you can receive a discharge notice from a nursing home or a facility. But yeah, you can't be using that if you're a long-term care community, and you are saying that to residents that if you don't do this, we're going to kick you out because you're not following the doctor's orders and you're going to get us in trouble, that's not the reason for doing it. A facility will not get in trouble if they are following what the resident wants and if they develop that care plan that I was talking about, that's done in a thoughtful manner and that gets revisited on a continuous basis. I see, Lawrence, you have your hand up.
Right, I just wanted to address that point. I just did a hearing about 2 weeks ago, where the basis for the facility's discharge was the resident's own safety, and it was based on the resident refusing treatment. So it's not just an empty threat, it's a threat that they will follow through on. Now, I don't have a decision yet from the hearing, so I can tell you what the ALJ decided, but that was the basis for that was the stated basis. And that was the evidence they put into the record at the hearing, that it's because the resident was refusing treatment, therefore his safety at the facility is endangered.
Well, I certainly hope that for this resident's sake, Lawrence, that it doesn't, it doesn't get honored, that discharge, because that's a direct violation of their, and I'm sure you, as a very good lawyer, I'm sure you made that point very clear. And I hope for that individual that the ALJ actually listen and takes that in. Kathleen, you did also make that comment that it gets very complicated by dementia, that can really be complicated. Lisa, do you have any thoughts on that when it comes to with people with dementia?
Well, being relatively new to this, I haven't dealt a lot with that situation with dementia patients, or residents, excuse me. I do see that there lies a lot of complication in that.
It does. And I think part of it is some of the complication that happens is because sometimes the person may be decisional in the morning, but not in the afternoon. As the day goes on, the dementia can get, their decisional ability can get a little worse.
Now, I
But,
have seen that. I've seen a lot of that on other topics, just not with whether or not they want to take medication. But I have dealt with a lot of dementia patients who can carry on a conversation and be very cognizant and follow what's going on, and even remember the last thing that I said to them when I was there the week before or whatever. But in terms of whether or not they should be taking their medication, I just have not dealt with that yet.
And I think what Jack's brought up about that individual that might be sitting in their poo, here they are, they go to the bathroom on themselves and they don't want to get changed. And again, this becomes because as a nurse, you know what's going to happen. It can lead to the skin breakdown, really make some other complicated issues happen for the individual. And then the facility might get in trouble for this. But again, if that education, if the person is non-decisional and it gets read as they're not being able to make that decision, and it's a matter, I still, at any moment, from a person who has worked with dementia for so many years in my career, I always want to get to the root cause of why the individual does not want to get changed. Is it because of embarrassment? Is it because of lack of motivation? Is it because of there's even can be that sense of loss? What is the reason, and try to address that. And that's where we get tapped. You've got to, as a building again, try to address why is the individual saying this. If they're saying, do not change me, even if they have dementia, they made that extremely clear that they didn't want to be changed, then it becomes my responsibility as the facility, as the staff that's working with the dementia individual, to figure out why the individual does not want to be changed. And we have to take a look at how we do it. Is it because they are embarrassed? And so they don't want to draw attention to themselves. It wasn't me who did that. That was somebody else. There can be a lot of feelings around this with people with dementia. And if that gets root caused, trying to figure it out, we're doing better by the individual, and we're making sure that we are listening to them. And if we wind up going to a place then where we see that their decisional abilities are impaired, that they are not able to articulate their decisions, even with the dementia-related diagnosis, then that is when we can go to the POA and say, and it might be a lifelong thing. They might have always been this way. That's where we gain that information. As a facility, we cannot be the ones to make these decisions and choices for people. We've got to look at past history, and we need to look at what the individual is saying. So with that, let's talk about, if my computer isn't locked on me, which it seems like it is, there we go. Participate in care plan and treatment. So everybody has that right to have a care plan, to be able to participate in that care plan, and to be able to participate in what that treatment is going to look like. How many times do we say to a resident when they're in a care plan meeting, how many times do we say to them, so this is an issue that we brought forward. We realize that you have you've been a diabetic your entire life. How have you managed your diabetes your entire life? And bring that into the treatment plan instead of, so this is how we're going to treat you. We need to ask those questions. How did you spend your day throughout the course of a day before you came here, so we can give you that same day that you had then, we can give that to you now. Asking people those questions so that they're involved in what that treatment, what that care is going to look like on that ongoing basis. Lisa, do you have anything further you want to add about this with care planning?
Well, I just feel like, all of us want choice and control and to be able to make our own decisions in our lives. And that does not stop at that door when they enter that facility. They still want to be able to make their own decisions and make their own choices. So I have started probably in the past few months, really, I'd say about 3 months, really recommending care planning to people. And it's been surprising to me that sometimes they don't realize that if they want to make a change in their daily routine, for example, that they can ask for that care plan. They're surprised by that. I sometimes do get in situations where the facility says, well, they just had a care plan, so they don't really need another one right now. Let's just have a meeting. And I feel like, and I'm in that situation right now with a facility that I've been pushing for a care plan. We keep having just meetings and not actual care plan meeting. And I don't know if the reason is they don't want to write the requests that the resident has into the care plan. I don't know if they're trying to, I feel like they're trying to control the narrative a bit and not let this resident have her say in the changes that she wants. But we're getting closer and closer to actually having that care plan. But the resident was just surprised that she could even ask for another one.
Yeah, you can have one at any time. And just because, so I think that's a piece for everybody to understand. You can have a care plan meeting. Care plans can be changed. Yes, there are scheduled for the most part in long-term care, in skilled and intermediate care, many of the other types of long-term care facilities. They're scheduled to be every 3 months. And there's a whole assessment process goes around that, a whole assessment process. And just because a person does a care plan meeting doesn't mean that you have to do that, all those assessments if they were just done a month ago. So you could still meet using that same baseline information and update a care plan based upon what somebody wants and keep on track for the next scheduled care plan meeting, which may only be 2 months from now or another month from now. Keep on track with that so that your assessment schedule stays on track. But that way, then people can have a meeting when they want to have that meeting. And it's typically around particular issues. It's not about everything. Many times it can be around a medication issue, how they want to spend their day issue, or around a dietary issue. It's around that. And that's the part of the care plan that can be revised with the residents' input. And lo and behold, anybody else they want to invite to that meeting. They can invite the ombudsman, they can invite their next door neighbor, they can invite another resident, they can invite their family as they define it, they can invite a staff member that they want to be there, they can invite anybody because this is a meeting about them. And I always say it's rude to talk about people behind their back, so they should be there as well. I see Linda, you have your hand raised.
Yes, thank you. Linda Hubbard. I happen to work with Lisa. We are just right across, there's a wall that separates our office. I just wanted to talk a little, my background before I came to aging was about 20 some years and working with individuals with developmental disabilities who also had dementia. So and oftentimes when they get older, they would refuse care that's vital to their safety. Is you're talking about someone who doesn't want to refuse change. Well, sometimes you can come back later, or if that person's angry at you, you don't want to be the one to persist. We had an individual who was up in ages, and he with dementia. And he was always, and he knew that he used to be independent in all of his personal care. So he would often refuse or think he just did it. But when we started, at one time he was married. So when we started talking to him about his wife, he would calm and let us do those tasks. So sometimes it's a matter of have somebody else. Hopefully there's in their chart what makes them happy, what makes them calm, maybe the approach, something to talk about, maybe it's music. So there's all different things to do to, to encourage somebody to participate in personal care tasks or their care. So it still is their choice, and they should always have an informed choice too. That's my feeling.
And Linda, I think what you said is very important. It was you explored, you dig deeper. You don't just say, you got to do it. You got to dig deeper to figure out what is that. And it might be my approach. It might be that there's an unfamiliarity with you. But once I start talking about your wife, I start talking about things that are familiar to you, it eases that anxiety. And then that changing opportunity to be able to change the person, the individual wants it then, and they'll allow it to happen. Mary, did you have a comment?
Yes. As far as, okay, sorry, it went out of my head. Never mind.
That's okay. Interrupt, Mary. Put that hand back up when you want to share it again. Donald, did you have a question or a response?
Yeah, I have a comment that I will try my best to make a very short comment, but I want to share my perspective from the point of view of having been a caregiver in serial caregiving for my two parents for a total of 30 years, and of being a person who turns 74 tomorrow. So being in my own elder years, dealing with the issues of my own mortality. And what I'd like to do is have people reframe this whole thing, because what happens is we enter into conflict over issues through frustration and that sort of thing. But I would like for us to take the communities back to the beginning, when the major shareholders are the patient or client or resident, however that person is identified, and then family members or immediate supporters for that person, whose roles may include being POA, and then all of the providers who are there, social service providers, medical providers, all of those people who were there. And I think the first place that you start off is with the recognition that the person's life, condition, or even capacity belongs to that person. That's who owns it, okay? And they get to make the final decisions about what happens to them up to the limits of their capacity. So unless someone is medically or legally determined to not have sufficient capacity, the final decision should rest with them. And I think that everybody involved, you start out as persons of goodwill. Everybody wants the best thing, but there are some things that are just true. Certainly nobody who becomes a patient, a resident, or a client wants to go into congregate setting and to long-term care. And no person who has made a commitment in their youth to be allies to people at this stage of life want to see them suffer. So we all start with good intentions, and we have to realize that we need to try to avoid this conflict by recognizing that the life does belong to that person. And that person has the right not only to refuse care, but to decide when she or he has lived sufficiently for themselves. And unfortunately, general medical care in our country emphasizes the quantity of life over the quality of life.
Yeah.
And the residents themselves oftentimes are at a place emotionally and developmentally where they understand that it's about the quality of life over the quantity of life.
Yeah, agreed. Very well said, Donald. Very, very, very well said. You know, there's been a lot of talk about language and the language that we use in long-term care, and people are changing from the word caregiver, because that means I'm giving you care, instead of care partner, and being a partner in the individual's care. And I think that that can just start to change things in the way people approach. I'm not giving this to you. I'm partnering with you in what it is that you want. So very well said. Very, very well said. Thank you for that. Also, people have access to the medical records. You have that right to have your medical record at any given time that you want your medical record. So I know I was standing at a nurse's station one time with an individual, and they were like, I have no idea what medications I'm on. And I'm like, is this something that you want to know? Absolutely. I just don't know what they are. And so I was like, do you want to go ask the nurse about this? And he said, yes. Went up to the floor nurse, the nurse hit print, gave it to him, and he's like, thank you. He had no idea what pills he was getting. So that everyone has that access to be able to get that. It shouldn't be secret information. It should be very much for the residents to be able to have. Mary, do you have a question, response or anything to share?
I'm yes and no. I'm taking a step back to the care plan.
Okay.
'Cause I remember what I was going to ask before.
Yes.
Basically, I was in the nursing home a year before I found out a care plan existed. I found out because as I was reading through the residents' right booklet that you guys put out, it kept talking about it. And I was like, what the heck is this? So I asked the head social worker, and she said she'd never heard of it. So after I'd been there a year, I found out it really did exist. And I told them I wanted a copy of it. It took 3 months before I ever saw it. And I suggest that every resident in a nursing home ask to see their care plan if you're not already seeing it, because mine was completely fabricated. I mean, they'd met with me. I'd never met with them. I am not at all, I have no sense of dementia, in case you can't tell. And they had meetings we'd had. They had that I had medical conditions I don't have. They said I had heart disease. It was in my medical records. I mean, so after I got the care plan, I finally asked for my medical records. It took another 3 months to get my complete medical records. 3 months. So
Yeah.
6 months to see all of that. So just be aware, it's not always easy, but every single resident should see their care plan and insist on it, because it may not be as easy as it can be. Some places it is, some it isn't.
And Mary, with that, I also encourage people to always get that put into their care plan as one of the things that they want in their care plan, to have it written in their care plan as a need. The individual would like a copy of their care plan anytime it is revised, and that should be something that happens on an ongoing basis. So, because you're absolutely right, people should have their care plan. It's their life. It's their directions to be cared for. And if I don't know what those directions look like, how do I know if they're doing it right by me? Privacy.
Sorry, they were setting up goals for me that they were saying I was achieving, and I never knew about them.
Right. And that's the piece. I mean, to me, a goal should be written. It should be written as, so this is what we've identified, what it is that do you want to see with this? Instead of written just to look pretty on paper. And many times that's what care plans are supposed to look like in long-term care facilities, is they look pretty on paper, and they shouldn't. I think they should look ugly on paper, because they should be used, and they should be accessed, and they should be crossed out and written on over and over and over again to show that you're really looking and working with the individual for what they want. Lisa, do you have any comments that you want to share around privacy?
Well, I've just noticed in my short tenure that I feel like most of the residents understand that they have that right to privacy. That's not really the issue that I see. I just see staff members who are in a hurry. They're working a long shift, or they're trying to get to, 8 residents before a certain time, and they just rush into the room and then rush back out without knocking, without even, a lot of times without even acknowledging the resident, saying, hey, Lisa, how are you today? Do you remember me? I'm Mary, or whatever. And a lot of times when I talk to residents about that, they can't even give me the staff member's name a lot of times, because the staff member, whoever it may be, that's rushing in and out, is doing it in such a manner that they're not taking the time to get to know the resident.
Mhm.
And yet they're not taking, and they're not taking the time to knock on the door or pull the curtain or do whatever it is that they need to be doing to ensure the dignity of the resident.
Yeah, so true. Stephen?
Yeah, so Lisa, on the note of staff not saying hi to the resident, I would like to issue a challenge to all of the staff who are on this call, or who are going to listen to it when it's on YouTube later on. Find that wheelchair that's sitting back in a storage room somewhere. Because I mean, there's at least one wheelchair stored somewhere in the facility, and sit in it for a day. Spend your entire day in that wheelchair and watch how many people just look over you who don't say hi to you.
Mhm.
I'm embarrassed to share the story, but I met a man with a standing wheelchair, and it was one of those that when he could just pull a couple levers and he would stand up, and it was amazing. And again, I'm very embarrassed by this, but and it was years ago, it was back in 2011, I think, when he showed me the standing wheelchair, I gasped and I said, "You're human." And when I said that, I realized, oh my gosh, I've had this prejudice in my mind all of these years. I never realized it.
Yeah.
And how many times did I look over someone who was sitting in a wheelchair? So I encourage staff, remember that these people that you're working with are people, number one. And then number two, try out that wheelchair, because that will show you how you and how other people have been treating residents, even, just a small way. But I think it makes an impact.
Thank you for your honesty with that, Stephen, because that is so true. Jax, did you have something you wanted to say?
I do. And I'm going to go from the staff side of this.
Yes,
I challenge all people who are on here as well to
Mhm.
then sit in the shoes of a nurse who has to pass meds for every 2 hours, help with potential falls or other things that I have to do. And now this is every 2 hours they have to do this. They have to get all their meds out to all the people on their staff. And we're talking about staffing shortage issues. We're talking about nursing home versus hospitals. So in this instance, I'm going to defend them because I've been in both shoes. It's
Mhm.
not easy. It is not an easy task for them to do these things. And from what it sounds like, you're making it sound like they don't do that. In that moment, you can't assess every nurse or every staff member as not being kind or watching someone simply because you saw one instance or a couple instances. You can't do that. You can't assume we don't care because we go into a room and that one instance where, oh my God, we forgot to do this, but we got to go, especially the CNA staff who has to then answer every call. They may have 12 or 13 on theirs. Half of them are dementia. You may have obese patients who then you have to, get them into the showers, 2-3 showers a night. If you have morning shift, you're looking at 2 meals a day. You're talking about feeding people. So sometimes when we're talking about compassion, which is what you're exactly talking about, it's exhausting. It's very
Mhm.
exhausting for these people. But don't get me wrong, I've seen horrible situations and I've worked both sides. So I've seen horrible situations. But when you put that out there, it's under the assumption that they don't care. And sometimes they just can't care. And there's a difference between don't and can't. So you should put that out there for those who don't care versus those who simply just, they're exhausted, they're overworked, and they're doing a thankless job at this point because people were basically telling them, hey, COVID doesn't exist. We're going to spit on you. You're liars. And this healthcare industry has gone through a lot over the last 4 years. And the people in it have gone through a lot. Nursing homes, healthcare as a whole. Don't get me wrong. I think that I went into this industry because I love older people. I love helping people. But don't get me wrong also. This has been some trying years, the last few years. I wanted to leave the industry because of it. So it's hard. So when you put that out there, put the challenge to people who don't care versus those who care, but just are exhausted and just, it's like when you go home after a long day, your kid's yelling at you to pick them up, but you're just so exhausted, you can't do it because you just don't have the energy to do it.
Yes.
That you don't want to, you love that child, but you just don't have the energy to do it. And so it's exhausting to sometimes do it. No excuses for it, but just to explain that that has to go out with an addendum to it, to specific groups, not every group, just to
And-
say.
And
Jax-
Jack,
Oh,
go ahead, Lisa.
oh, I'd like to say to Jax, thank you for saying that and clarifying that, because I actually do see a lot more compassion than I see not compassion. And I feel like that obviously no one would be there if they did not care about these residents. I feel like you're right. The staff do care about the residents and they do get just overwhelmed at times. And you're right. We walk in and we're there for 5 or 10 minutes with this resident, speaking to them about something, and someone rushes in and rushes out. And that is what we see. And in this discussion, I'm just bringing up things as a new RO that have been, for me, surprising or eye-opening, I guess, in my role. And I really do work hard with my staff in my facility to help them work or learn more about residents' rights, and for us to have a good open relationship with them, because I feel if we work with the staff, we're all working together for the residents as well.
And I don't think anybody's
Agreed.
entered into this path. I refuse to believe that anybody who works in this path doesn't care. I feel that everybody does care, but I do feel that the emotion can run, like you said, Jax. You know, I feel everybody is compassionate, but sometimes we get overwhelmed, and that compassion gets superseded by the overwhelmingness of what it is that I've got to do at that given moment. And I know that I thank you for being that person to keep us in check. That's important. That's what this is about, is bringing all entities together, these meetings. That's what they're about. Nick put into the chat, as a legal guardian while also advocating for my brother, all I ask is respect me as a member of the care team. Stop pushing me away, because I am the expert of my brother, while I am respecting the expert of your role and responsibility as a nurse of others. And I think, or others. And I think that that is an important piece too, is to understand everybody's role. And they're important. They're extremely important roles. None of us could do this without. That's very, very important. And we have to be respectful of each other's roles while we're also educating each other on these roles. So I can share my perspective as an ombudsman with the staff member who can then understand what I do, and vice versa. And then the same way with the residents, the same way with the families. Donald, did you want to share something?
Yes, just very quickly, again, I just want to say to Jax and to everyone who is exhausted because their responsibilities are overwhelming, that you are appreciated more than you know, and perhaps more than you are led to feel. There's no one who isn't grateful for people who are on the lower end, rather the higher end of service providers, because it is the nurses, the CNAs, the housekeepers, the food service people that are actually more engaged with residents and patients and clients than anybody else, more so than administrators and physicians and surgeons and that sort of thing. But again, we have to all come together and take out the adversarial part and come together in advocacy. And I can tell each of you that in your capacity, whether it's medical, whether it's behavioral, whether it's administrative, supportive, or whatever, despite all of your skills and all of your experience, the one thing that impacts the person most is your sense of humanity, your personhood, who you are. The number one need of people in our age group is to deal with social isolation, our relationship as people. So if you're losing that, then we got some structural issues that need to be dealt with, how we staff or whatever, but we cannot sacrifice that.
And Mary, did you want to share one last comment? Very well said, Donald. Again, thank you.
Say I applaud Donald's comments. I just wanted to say that I understand that the nurses and CNAs work like dogs. There's just no way around it. I experienced it. I still have both that are still friends of mine, even though I've been out of the nursing home for a number of years. But literally one of the ones that I still consider a friend, and actually every nurse I had, as a diabetic, I also had a continuous glucose monitor. So my blood sugars are on my phone and I can see them at any time. So before each meal, they would yell across the dining room, "Mary, what's your blood sugar?" And I'd have to yell it back. For a while, I got up and went over and told them because I didn't want to do that. But that's just, I mean, they were delivering the medication to people at my table anyway. They could have asked then, but mostly they didn't. And that goes against my HIPAA rights. So I
Mhm.
understand the busy, but there are lines that shouldn't be crossed.
Yeah, and that's so true. All this stuff is just bringing it all together, and none of us are perfect in any of the roles that we do. And it's just making sure that we're listening and we're attempting as much as we possibly can to put the individual first that lives in a long-term care community. With that, I think you guys have all very succinctly have put a wonderful end to this presentation for today. We're going to pick up on this. I personally am thinking the next meeting, we've got multiple other, there's a whole other column of rights over here that I want to go through. But I think breaking these down and talking about each one gives heart to that right and the different perspective of all the family, the residents, and the ombudsman. And the staff. It's giving perspective of everybody together to truly understand these so that we can all do better. And we can all, I hope we understand that we all can do better. So with that, I'm going to go ahead and I'm going to stop the recording. Hopefully the recording picked back up.